Our next presentation is from Javera Khalid, a biomedical scientist and lecturer at Aga Khan University, so coming to us from Pakistan, and she focuses on reproductive and developmental biology. So I'll hand it over to you.
Thank you, Anu. Hi, everybody. My name is Javera, as Anu has mentioned. I feel like I need to put a disclaimer out there. I am way out of my depth at this conference. I am not a modeler or a statistician. I'm actually a reproductive biologist, but I had this idea and I asked my modeling colleagues to help me with it, obviously. And so we're just going to go over what we've learned from using machine learning to determine the association of maternal characteristics and serum biomarkers with some newborn outcomes. So, a bit of a background, which I don't know, most of you might already be aware, so apologies if this is a bit of a repetition, but pro-inflammatory biomarkers have been implicated in the molecular pathways that lead to the onset of labor and ultimately adverse outcomes as well. And a number of biomarkers have been linked to outcomes such as hypertension, preeclampsia, preterm births, which can obviously result in small for gestational age babies with or without stunting and or wasting. And these molecules can be upregulated and downregulated depending on the pathophysiology implicated in the outcome of interest. And obviously, when you're talking about the in utero environment, growth restriction begins while the fetus is still inside the mum. So it's important to look at what sort of changes are happening while the woman is pregnant and during gestation. And any growth restriction that begins obviously in utero has been correlated with cognitive delay and vaccine immunogenicity in later years as well. So this was a retrospective data analysis that was done on samples and data that we obtained from this initial study, which is called the Amani Biorepository Study. So Amani stands for the Alliance for Maternal and Newborn Health Initiative. And this was mainly a biorepository study that was done in Pakistan, India, Bangladesh, and Tanzania to show that biobanks could be a sustainable platform for research into adverse pregnancy outcomes. So we identified pregnant women who were less than 20 weeks of gestational age through a married women surveillance registry in Pakistan. And these women were from peri-urban areas or slums from the city of Karachi in Pakistan. So we recruited women between the gestational age of 8 to 19 weeks based on ultrasound confirmation of pregnancy. And at the enrollment visit, we took their blood and urine sample. Antenatal care visits, we took also blood and urine samples. And this antenatal care visit was done between 24 to 28 weeks. And then at delivery, we took placenta, maternal stool, cord blood samples, and also performed the newborn heel prick test. And postnatally, we followed the mother to get some more blood samples and urine samples. And we also obtained paternal and newborn saliva and followed up the baby until 12 months of age to obtain infant blood and stool samples for further analyses. So this study will be focusing on the biomarker testing that we performed on maternal blood samples that were taken at the ANC visit, that is 24 to 28 weeks. So the objectives of this study were to identify, using retrospective data, any predictive models for newborn outcomes at birth by applying various machine learning methods, and also to identify maternal serum biomarkers that could be strong predictors for these growth outcomes for newborns. So the outcomes we were particularly interested in looking at were stunting, which is height for age, underweight, weight for age, less than 2 standard deviation, wasting, which is weight for height, and then small for gestational age, which is defined as birth weight less than the 10th centile for gestational age. So we applied 3 models, which is the logistic regression, random forest, and the support vector machine. And each model integrated maternal serum biomarkers. Now, these were a panel of 13 biomarkers that included placental growth factor, VEGF, calcium, ferritin, albumin, and such. And we also included phenotypic variables in these models. So socioeconomic status, parity, gravidity, mid-upper arm circumference, history of any previous stillbirths, preeclampsia, etc. And for all models, we adapted a 70-30 test train split. So this is our study population. We ended up enrolling about 2,500 women in the Amani biorepository study that resulted in 2,352 live births. From these, we had standardized anthropometric measurements of biomarker data available for 1,937 participants, of which 31% of the babies were still small for gestational age, 21% were stunted, 12% were wasted, and about 23% were underweight. So this is the models for stunting. On your right-hand side, you can see the feature importance plot. And then on the left-hand side, we have the sensitivity and the specificity plot as well. And from here, we can see that the random forest ROC curve has an area under the curve of about 0.87 and the logistic regression 0.66 and the SVM ROC curve of about 0.61. So clearly showing that the random forest model is outperforming all of the other models. And in terms of the feature importance, we see here soluble FLIT, PLGF, and pregnancy-associated plasma protein A as the top three features. And if you go a bit further down as well, we can see BMI, mid-upper arm circumference, and mother's age as also important factors implicated in the stunting at birth outcome. Now, again, we replicated the same exercise for our wasting outcome. And we can see here also that our random forest model yet again outperformed with an 86% predictive ability compared to the logistic regression model, which had 71% ability, and the SVM ROC curve, which had about 59% predictive capacity. And then on the, again, on the right-hand side, we have PLGF, SFLT, and PAP-A, again, identified as the top three features that could lead to wasting at birth. And then again, for underweight as well, we did the same exercise, and not surprisingly, the random forest model was also 75% accurate in determining this outcome at birth. And also similar to the last one, we have soluble FLIT, pregnancy-associated plasma protein, and SFLT, PLGF, as the top three important features in underweight at birth. So likewise, our last outcome was SGA. Again, here we also have 75% predictive ability of the random forest to determine this outcome. And similar to the last one, we have PLGF, ferritin, and SFLT from the biomarker list as the top three features important for still small for gestational age at birth outcomes. So in conclusion, through this work, we were able to demonstrate that biomarkers such as PLGF, SFLT, and PAP-A are strong predictors of malnourishment in children at birth. Specifically, placental growth factor was identified as the most important biomarker for all of these outcomes. And it's good to see when, these models and stats corroborate with biologically possible findings as well. And this is what we see also in literature, that the role of these biomarkers are important in angiogenesis and placental development and implantation. So naturally, this makes sense when we saw these results. And as a result, also, we were able to find out that we can factor in these biomarkers for planning and designing any future trials that are targeted towards the improvement of newborn growth and development. And also another important finding from this exercise was that random forest models actually could accurately predict malnourishment. However, these obviously need to be further calibrated before being used as a screening tool in pregnant women. And lastly, this study was encouraging to see that we could use pre-existing data and other tools and technologies such as machine learning to accelerate progress in maternal and newborn health towards the prevention and diagnosis of these adverse outcomes, and especially in developing countries where the burden is disproportionately high. Thank you very much. That's all for me.
Thank you so much for an excellent talk. Are there any questions in the audience? Please. Oh, sure.
Thank you. Very, very interesting. I was thinking the biobank from where you took the information, the prevalence of some of the endpoints of the disease was relatively high. I was making up the sum, almost 50% of the population had one of those 4 endpoints. Just wondering if that would give different results in population with lower prevalence of those problems.
Yeah, you're absolutely right. But so the next step for us is to obviously collate data from other sites. This was only performed on our study site in Pakistan. So the next thing we want to do is we want to collate data from our sites in Tanzania, Bangladesh as well, and see how these models perform. And obviously, the outcome numbers will be different for their country as opposed to ours. However, there is going to be a bit of similarity because this is coming from a very underprivileged and under-resourced population. So, naturally, there's a lot of food insecurity, nutritional deficiencies, and not a lot of health-seeking behavior as well. So it's not surprising that we're seeing these kinds of numbers.
Hi, that was a really great presentation. I just had 2 kind of questions related to what Santiago said. One, what would kind of happen if you throw in a non-biomarker variable like mother's birth weight into this? Does that like wash away? Yeah, like things like growth factors. So that's one. And second, random forests, as far as I understand, are kind of like unstable models in the sense that they are dependent on the data set that you're working with. So is there an idea to use other models that might work better for like across data sets or study sites? Thanks.
Yeah. So addressing the first part of your question, I think when you say mother's birth weight, we can consider as a proxy variable for that would be gestational weight gain of the weight, how much the mom has gained during her pregnancy until childbirth. We don't have that variable for this study, but that's actually a very good idea, and we can include that. But however, I think we included other variables such as BMI and mid-upper arm circumference, which was implicated in the top feature label list as well. So it makes sense that, if the mother is already like malnourished or undernourished, obviously it makes sense that she's not going to give birth to a very healthy baby. As for your second question, I would refer to my modeling colleagues. Yeah, but I think from what I've also been reading in literature as well, we have a lot of other models now that we can test, such as the XGBoost and other models as well, which we hadn't done at this point. But I think going forward, and especially when we're getting more data and our sample size is going to increase, I think that will be a very good idea to sort of trial that as well and see how they perform.
Thank you. Thanks so much for the presentation. It was very interesting. So much curiosity stemming from it, but I'll try and be brief with my questions. The status, the socioeconomic status that you mentioned, can you speak a bit about what that was in practice, what proxy you used for it? And also, I didn't see it in the results after. So that doesn't mean it was very small and didn't make it on top.
Yeah, it didn't make it on the top, basically. So we normally use wealth quintiles for as a proxy for socioeconomic status as well. We also use education level and occupation as well, and all of that kind of factors into the overall socioeconomic status. But obviously, that wasn't identified as one of the very top features. But yeah, those are the usual variables that we collect and use.
Yeah, I didn't get to ask him the last one, so I'm the moderator. I'm in charge. So the serum and biological data you was collected in ANC visit, right? And given that there's some recommendations for 8 ANC visits, does the timing or number of ANC visits come into play in, ideally you should collect data on the 4th ANC visit or a later ANC visit to improve the predictability of your model?
Yeah, so the blood samples that we took and the biomarker tests that we did were just performed at one sample time point. So if those samples were taken longitudinally during that ANC period, say for instance, if it was across 4 visits or during the second trimester, for instance, obviously that would have different results, but obviously these are not longitudinal samples. These are a single time point sample taken at mid-pregnancy time point, gestational age. So yeah, that it'd be really interesting to see, but because we didn't have that data, we've just used that single time point sample to put into our models. But yes, over time, seeing how these levels of biomarkers change in pregnancy, that can also be a very interesting concept to look at.
Thank you so much.